So I'm Adam. I'm a pastor at Clackamas United Church of Christ. Been there for about 3 years, and interested in healthcare. So happy to be here. Patrick, next.
Hello, I'm Patrick, First Congregational UCC in Corvallis. I'm in the same congregation with Mike, and I worked in medical health field for many, many years before I retired, 35, 40 years. And so I have an interest in it because I saw some of the things that are going on that bothered me a lot. And fortunately, I had Mike as a member of the church, and he set up a healthcare team, healthcare ministry. And I've been with him since, and I've enjoyed it, and I think it's a real need in our country, in our world, I should say.
Absolutely. Rick, how are you? Rick, you are muted, and Mike may have to, there we go. You're good now.
I'm doing well, thank you. I'm a retired psychiatrist living in Albany. I'm a member of First Christian Church of Albany. I'm the one of the co-conveners of the Faith Caucus for Healthcare for All Oregon, and I'm working on it locally in the Albany area as well.
Wonderful.
And in my church.
Wonderful, wonderful. Who is the pastor there now?
Tim Graves.
Yes, Tim was at what church? He was at the UCC church in Condon before.
Yes, he was before this. Yeah.
Yeah. Always appreciate the close relationship we have with the disciples. So that's awesome.
Me too.
Eric,
I really like their international justice work, especially.
Yeah, it's a good team. Erica, you want to introduce yourself? I introduced you, but you can talk for yourself clearly. So,
thank you. It must be Monday if you're letting me talk about myself. Yeah. My name's Erica. I'm an active member at Clackamas United Church of Christ in Clackamas, Oregon. I'm super active in the Black Lives Matter movement, and there's actually a real connection to healthcare and yes,
That's not so long.
to healthcare and people of color, and even access to it, and it's even happening at protests now where people are getting hurt and are unable to take care of, are unable to pay for healthcare, and the police are hurting them. And yeah, so it's close to my heart.
There you go.
There, okay. Well, I'm Pamela Lyons Nelson, and I'm a member of St. Timothy's Episcopal Church in Salem. But I'm participating in this as the convener of the Western Episcopal Diocese of Oregon's Commission on Poverty and Homelessness. And so Mike suggested I might want to tune into this, and I was really appreciative of that invitation. But a lot of what I do is go around to different congregations and talk to them about universal health care, answer a lot of questions. That's taking different forms now because of COVID, but we can do this online too, and we do. So is that enough, Mike?
Yeah, I think that's good. So this is Mount Hood, by the way, and we've come a long way in healthcare, but we sure have a long way to go. And there's crevasses and there's fumaroles and cliffs ahead of us. But from a people of faith standpoint, we want to be sure in our system that we end up with fairness. We want freedom, and we want our faith to strengthen us in fighting for these things for everyone. This is a meeting a program that's sponsored by the Healthcare Ministry of the Justice and Witness Ministry Team of the Central Pacific Conference and Mid-Valley Healthcare Advocates. So, better tell you about myself before we get into the sick care system. I was a radiation oncologist for 35 years, and in the last part of my career, I started seeing things that were pretty disturbing. Patients coming in with advanced cancers, and that didn't make sense because we were getting better at diagnosing cancer. And some would avoid treatment or coming in for years even, and because they were so afraid of cost. And finally, they would face a crisis that they couldn't ignore, and they would come through the emergency room. That's how I got to meet the emergency room doctors, some of whom are still my good friends. But then, of course, we were behind the 8 ball trying to catch up with what this patient needed. So that happened repeatedly, and each time it was like being socked in the gut because it shouldn't have happened. And I realized when I started reading that other countries didn't let that happen to their people. So I retired 14 years ago and decided I was going to spend my retirement trying to stop this kind of tragedy from happening like it is. So I found out, and you probably already know, that our current system is a sick care system. It thrives on us being sick. That's how hospitals and doctors make their money in this system, unlike other countries. So in addition to that, the price that's charged is extremely high, way beyond reason. And for all that, we get an underperforming system where we have poorer outcomes than other industrial countries. Obviously, it's inequitable. And as we found out with the pandemic, our sick care system hurts people, particularly those who are on the margins to start with, people of color, people of low income. It's just a terrible system, in spite of all the good doctors and hospitals that we have. And furthermore, it's unsustainable as a society and financially. So here we see what's happened with healthcare costs since 1955 on a 45-degree slope, almost upward, not stopping. And this hasn't really changed since this was, if anything, is worse since 2014. Whereas the other costs of living, the clothing, housing, and health and food have come down. Obviously, this is unsustainable. Per capita, we're spending about $11,000. Now, that doesn't mean everyone is generating that kind of cost. Maybe half of us in a given year are not generating any significant cost. But in the other half, some are losing their bank account in their homes because of hundreds of thousands of dollars of cost. And none of us know when we're going to be falling into that upper half. If we look at monitors of how we are doing as a nation, if you look at some indicators, we're doing pretty darn well. At least before the pandemic, the gross domestic product was rising. Unemployment was falling. The stock market was on the rise. And the annual inflation rate was falling. But there are other ways, probably more realistic ways of looking at our society. Life expectancy was falling. 40% of Americans can't pay a surprise bill, not because they weren't handling their money well. Many people had 2 jobs just to keep their house, but they don't have money left to pay a surprise bill for a medical procedure. And deaths of despair, drug overdose, depression are at an all-time high. To compound things, trust in institutions that we might depend on to solve these things for us, trust is at an all-time low. I'm going to let somebody in, and if anybody has questions, we can take a break there, and I'll unshare. Does anybody have any comments at this point? I'll just continue then. I'll go ahead. We just got John Morris, who joined us. Welcome, John. Now that we're taking a break, any comments so far?
Just that surprise bill, Mike, it actually was a surprise bill of $400 at the,
You're gonna sit here?
40% of Americans couldn't pay a surprise bill of $400, which is
Oh,
not very much money, but they don't have that. So that's even more alarming.
yeah, yeah. So just everybody knows to know John Morris. He's also a member of Congregational Church here in Corvallis, and was a scientist at OSU in biology, as I recall. And
Well, thanks for the introduction. That's enough. Thank you, Mike.
so how do we currently get our health care? Well, about half of us get our health care through our employer, and this happened because of an accident of history. During World War II, there was a wage freeze, and employers wanted to attract workers, and so they offered healthcare benefits, and we started this slide downhill. A small portion of us get our healthcare insurance through the marketplace under the Affordable Care Act. 8.5% of us remain uninsured now, and it's important to remember that those who do have insurance don't necessarily have reliable insurance. Half of people are underinsured of those who are getting their insurance. That means they're paying more than 10% of their income for healthcare in spite of having insurance. Then about 40% of us are getting our healthcare through publicly funded insurance systems such as Medicare, Medicaid, the VA, and Indian Health Service. But what has our system brought us that's now based on private insurance? Well, not very good stuff. The insurance industry determines for us what services are available, how much is covered, who you can see, and what your costs will end up. So if you have a policy that looks like it will cover your needs, but the deductible is $5,000, you may not feel you can afford to spend your deductible, and so you don't go in. So that's the kind of underinsurance that many people are facing in this country. So if we look at a family of 4 getting their health through their employer, the premiums, if you consider what the employee and the employer pay, are around $20,000. And the total amount that families are spending is about 1/3 of their expenses for, quote, healthcare. But a lot of that is just to service the health insurance industry. And the reason that we include the employer contribution as a cost to the employee is that health benefits are basically instead of wages. Why does it cost us so much? Well, one of the main reasons is just the blatant complexity of our system. We have 900 insurance companies, each with a dozen plans, and we have all of these filters that are in our system. And each one of these little triangles, or they're rectangles, represents an agency, a clerk, and maybe even an entire industry that is there to make some money, obviously, and to protect insurance companies from unwanted losses. It's just a web of obstructions. That's one reason. That's one of the main reasons this is so costly. By the way, Dr. Chun-Wei Chi just joined us. Let's take a break to greet him. I'm going to stop share. I'm going to ask Chun-Wei to unmute and also greet John Hawkins. Hi, John. Tell us a little about you. How come you're interested? And over here is Chun-Wei Chi with a picture he took in where, Chun-Wei?
That's in Santiago.
Santiago, Chile. Chun-Wei, can you introduce yourself to the others here? Not everybody knows you.
Yes, I can join only for part of the time. That's why I wasn't able to join from the beginning, and I may not be able to stay till the end. So, but I would like to be part of it. My name is Chun-Wei Chi. I'm a professor in health management policy and also in global health at Oregon State University.
Thanks. Chun-Wei is being overly modest. He helped Taiwan create its single payer system and goes back every several years to help them tune it up. He is a professor of health administration, international track at Oregon State University, and we depend on him heavily for information on how we should behave here in this country. He has already testified before the Senate Bill 770 task force that is now meeting, and we'll talk about that a little later. So thanks, Chun-Wei, for coming, and come and go as you need to. I will share screen again. So everybody can see the pie graph. Why does it cost so much? Well, we started to see why. Just the tremendous complexity, and I'm sure in Taiwan, it would be a very similar, simple diagram over here, where the patient comes to the doctor, the clinic or the doctor sends a claim, and the single payer system, which in Canada is a provincial payer, pays that bill within 2 weeks. No haggling on the phone over pre-authorizations or denial of claims. A very simple, open system. And it turns out that the doctors are very happy with that. The primary care doctors are paid at least as much as they are in the US, and they do not have to deal with patients who can't pay for the treatments that are recommended. So here's another graphic example of the difference between our country and most other developed countries. It takes about, have to divide this, 2 billing clerks per bed in American hospitals, and this was true of Duke University, and it takes about 1 billing clerk for every 100 beds in Canada. So these are salaries, and therein lies a great deal of the cost. But behind each one of these salaries, there's a company, consultation companies that telling each of these clerks how they can maximize income from the services that they provide for taking care of us. It's a compounding system of adding cost where we don't need to do so. So that's just part of the problem. The other is that private insurance needs to make a profit, and their main goal is to stay in business. That doesn't necessarily align with keeping people healthy. So what are some of those expenses that go for things other than health? Well, last year, United Healthcare paid $627 million in royalties to AARP for the privilege of AARP advertising their healthcare system. Millions of dollars go for logos on sports arenas or for TV ads. That money should be going to pay nurses, doctors, pay for services that people need. So one of our former Republic, well, shouldn't say what party, former presidents said this in 1854. Well, the legitimate object of government is to do for a community of people whatever they need to have done, that they cannot do it all or cannot do so well for themselves in their separate and individual capacities. So we treat certain services as important enough to provide for everyone. We make sure that our government provides these. We don't do a good job individually at building roads or manning fire stations or doing schools. So we ask our government to make sure everybody has those services at a reasonable cost. Police protection. So that's following up on Abraham Lincoln's point that certain things we just don't do for ourselves. Well, turns out that healthcare is one of those these days. So everybody can see my screen again, I hope. Okay. So there's been a lot of thought about this over the past 100 years. Teddy Roosevelt tried to get a universal healthcare system so people would not have the problems that we are having. FDR tried to do that. Harry Truman tried to do that. Even Richard Nixon did. The resistance came from, I'm sorry to say, the American Medical Association was one of the major resistors to this. But now we have several bills in Congress and even in our own state that are heading us towards a universal healthcare system. So at the federal level, the one that we think is most suited to get us there, and this is an improved, expanded Medicare for all, not the Medicare that we know today. The Medicare we know today is very good, but it has many flaws. It is being privatized by Medicare Advantage. It cannot bargain with the drug industry for price. It cannot use standard evaluation measures such as quality adjusted life years to decide whether to pay for something or not. So there are many flaws that this bill would remedy. HR 1384, I encourage you to investigate that. Its Senate equivalent is S 1129, sponsored by Senator Bernie Sanders. The House bill is sponsored by Representative Pramila Jayapal of Washington. Those bills were introduced in 2019. They have had hearings. This year, an emergency benefits bill was introduced called HR 6906, and that one has been introduced because of the pandemic, and it would allow people to get their health care through Medicare if they have lost their job, their insurance through their job, and if they had no insurance beforehand. So I encourage everyone to look into those. This year, probably none of those three have a chance of getting to the floor, but of the three, the last one is the most likely.
Mike,
Go ahead.
isn't it also true that it would pay any of the out-of-pocket expenses for people who are insured?
Oh, good point. I didn't remember that. Thank you, Rick, for bringing that up. Share screen. So this is expanded, improved Medicare for all. And I think this diagram can show you why it means fairness and freedom for all. Let's see, can everybody mute? Make sure they're muted. So can everybody see this graph? So this is a graph that will show you compares the life expectancy in the United States to 16 other countries. And that's Austria, Canada, Denmark, Finland, Taiwan, Germany, Italy. We would like to be at the very top figure here. So where are we? At every decade of life, we are there at the bottom. So if you're 10 years old, your life expectancy is the lowest of 17 countries. Same is true at age 40. Same is true at age 64. Well, you're starting to improve. But look what happens at age 65. So I think, you know, there's a danger in us just landing on the flaws of our healthcare system, because that makes some people feel like we're not being patriotic. I think this slide is very patriotic because it shows that we must have the best caregivers and facilities in the world, or at least as good as the others, because this couldn't happen otherwise. Once people get access to healthcare, they have a good chance of surviving. It's just that all of these years, about a third of us find it unaffordable to go in for healthcare. There's some good news also for us here in Oregon. In 2019, the legislature passed Senate Bill 770 at the very last hour, and it created a task force, the Universal Healthcare Task Force, and that's the one that Dr. Chun-Wai Chi testified at last month. Its job is to create a politically strong proposal, and here are some of the members. Second from left is Bruce Goldberg, who was the director of the Oregon Health Authority. The lady next to him is a member, a leader in the Oregon Nurses Association. There's many others that are very well qualified. And so all of these on the top, and these two are voting members, and they've been chosen on the basis of diversity, geographically, and life experience. The others here are non-voting, but they represent, for example, legislators over here, and the director of the OHA here, and the Council of County Commissioners here, the insurance division here. So their job is to prepare a plan based on principles of fairness, equity, high quality care that's affordable, and they will present that plan to the legislature by the end of next spring. They've met twice, and they are taking testimony. As I mentioned, Dr. Chi already testified, but they need all of us. In order to reach a politically strong proposal, we all have to take part in making sure the task force knows what we want. So you can learn details of this you can going to our website, midvalleyhealthcareadvocates.org, mbhca.org, or copy that tiny URL. It will get you to the Oregon Legislature website, and that specific URL takes you to the task force. So tinyurl.com/Y46Y9EMG. And this now is Oregon law. Many people don't know that Oregon has already passed such a law, and it's Chapter 629, 2019. So back to our faith-based support for universal health care. The United Church of Christ has had a long history in supporting this idea. Even before this was 2009 synod calling on our government to create a plan that covers all people, presents no financial barriers, has comprehensive benefits, offers full choice of physicians and other healthcare providers, and eliminates ethnic and racial and other disparities. It would be publicly funded. This is the synod speaking again. This is what they are demanding. Publicly funded, even if it's provided by private medical practitioners, the doctors that people have now. So those are those bills again, HR 1384 and S 1129. If anybody says this is socialized medicine, I think without a pause, you can say this is socially responsible medicine. So our ability as people of faith can do what we do in many other areas of social justice, and that is speak up for those who can't speak for themselves. We can speak up to defend the rights of the poor and the needy. You can also get involved with Healthcare for All Oregon, which is a statewide coalition of 130 organizations, unions, businesses, churches, civic groups. The Central Pacific Conference is a member, as so are many member churches in the conference. As a member of Healthcare for All Oregon, members such as our church in Corvallis provide space when needed for meetings. We have a delegate to the annual meetings of Healthcare for All Oregon. We pay a stipend of $100 per year. And we participate in the Faith Caucus of Healthcare for All Oregon. But for our purposes, the main thing we can do, I think, is reach out to our own congregations and engage them in conversation. So to do that, I'm inviting you to become a member of the, or get acquainted with the Healthcare Ministry Network that's part of the Justice and Witness team of Central Pacific Conference. You can reach me directly at my email address here, and then get more information at this website. So just go to the Central Pacific Conference website and go to the ministries, and then one of the ministry networks is the Healthcare Ministry Network. So please get involved in this growing grassroots movement. We mentioned these organizations you can go to, become a member of HCAO, and donate money. If you find you can't do any other way of helping, please send money, because we do have an office and an employee to help us do our activities. So here we are, aiming for healthcare for all. We've come a long way. We have a long way to go. There's a lot of hazards between us and the summit, but with persistence and energy and enthusiasm, a little sense of humor, we can do it. We're aiming for freedom, fairness, and we're going to use our faith to help us get there.
Mike, thank you for that great presentation. Really great and informative. I guess my question would be, what are the barriers to getting this done? What do you see as the biggest barriers? And what was the organization that you said was against this for a long? Was it?
There are quite a few.
The
Yeah,
American Medical
one,
Association he referred to.
the American Medical Association.
Oh yeah, right.
Who is that? Is that composed of doctors?
Yes. Do you want to talk about the AMA, Rick?
Yes, last time I checked, they represent about 17% of doctors, and they have a
有上 email 花
disproportionate number of specialists who tend to have a different position on universal health care than primary care providers. Primary care providers are very much in favor of this by about 3 to 2, 60%. That would include internist, family practice, pediatrics, and psychiatry also is considered a primary care. All of them are over 60% in their support. Now, in order to keep this thing reasonably economical, or one of the ways to keep it more economical is to, they probably wouldn't pay the kind of very, very high salaries and charges that these specialists are paid for by private insurance. Would you agree with that, Mike? I mean, that's...
Yeah, right, I agree.
So that's one of the reasons that they tend to be opposed to it. And just in general, I think there's some more people who join the AMA because it looks out for their economic interest than you would find in the general physician population.
So the AMA has been so vitriolic in past years that once Truman put this out to Congress, the AMA hired a PR firm to create ads like the Harry and Louise ads of the 90s. They even sent their ads to Canada when it was starting to develop its universal healthcare system. But there's some good news with the AMA. They were last year part of a cartel with the insurance industry and the hospital industry to oppose Medicare for all. But with some clever sit-ins, the young members of the AMA, students, disrupted the AMA's meeting last fall. And as a result, the AMA dropped out of that cartel. So I think the wind is shifting in our direction.
Good. Thank you.
I'd like to know if Adam is interested in knowing more about the opposition to this. AMA, as Mike said, is only one of them. I mean, corporate healthcare is a huge entity. American Hospital Association, or AHI, whatever it is also a very strong opponent. The investors in Wall Street who invest in insurance companies, corporate healthcare, and whatnot, they're a force unto themselves.
Rick, I have a question. Rick, you were mentioning that the highest percentage of doctors, it seems to be, are in favor of the healthcare, but that the AMA is not. I don't see how to square that.
Well, that's why I mentioned that the AMA is composed of a subset of doctors who represent specialties disproportionately, make a lot more money, would be likely to lose under this. And a lot of people who join the AMA do so because it's like joining a union. You know, they look out for your economic interests. So those kind of people may be less interested in making sure that everybody has health care. Some of them, obviously not all of them. And obviously young doctors going into the AMA, they much more strongly favor universal health care. So there are certainly lots of them that do, but I'm one of the people who actually dropped out of the AMA because I was so disgusted at that time anyway, how much they were concerned about their economic interests rather than the patients and the general public.
Rick, were you saying that only 17% of physicians belong to the AMA?
Last time I checked, yeah.
That's quite a dramatic drop, isn't it? It seems to me.
Could be. I
Okay.
probably wasn't the only one that left them.
Well, I'm thinking back in the 60s, and so it seemed to me like almost all doctors belong to the AMA. That's,
You know, Patrick, I wonder if that wasn't part of a PR campaign to make it seem like those 17% or 25 or 35, maybe it was,
maybe it was.
for everyone.
Maybe so.
And I did remember my question. And the question is, according to my information, that it looks like we will be having, because we have such a shortage of PCPs right now, we'll have such a flood of people needing and using PCPs, because that's where our prevention and our primary care comes from, that makes a system like this work, that much of that will be done by PAs and NPs. Is this, and that is true in the Oregon Health Plan already. Is, at least that was my experience in my clientele in the Oregon Health Plan, that often the person who signed the medical form was a PA, or in some sense, in some cases with, because I was in mental health, it was a nurse practitioner. Do any of you who have experience in the medical field, have you heard about that? Is that part of what's getting baked into a new system, is that we will be able to have those people on tap right away because they're there?
Well, the task force, its job is to present a plan, including how to choose a board and how to make these very decisions that you're talking about. The task force itself will not provide those answers. They're creating the board and the guidelines to provide those answers. So then it'll become a matter of balancing quality and getting enough personnel. And I think that for many purposes, the nurse practitioners and surgical, I forget the name for the surgeons, will be able to do much of what the doctors are doing now. But we still need to have 4-year medical school to produce
Yes.
people who can recognize the zebra. You know, you always heard the thing that when you hear hoofbeats, think of horses, not zebras. But zebras come along, and that's where the extra 4 years is necessary in some system, is to have enough training that you could recognize the unusual.
Yes, yes. I agree with that.
Rick mentioned a couple of times the economic situation for doctors as being a reason to be against this. And I'm interested in that. I have a cousin who's a specialist, and he said exactly that when he started getting into becoming a doctor. He said, if we give universal health care to everyone, then nobody's going to want to be a doctor because they're not going to get paid. I smile when I say that, Rick. I see you smiling. But what is that? Is that fear-based? Is there any reality to that?
I don't want to make assumptions about your brother, but
It's my cousin. So it's a
that
little
would
bit
never
different.
cross my
It's my
mind
brother.
if I was considering going to medical school right now. The amount of money I was going to make. So there's a wide divergence of opinions on that, I guess.
And Adam, remember, all questions we have already been answered by other countries that have universal health care. Every one of our challenges has been there. And in Canada, after Saskatchewan broke the mold and was spreading, the doctors found out they were earning more. And not only were they earning more, but they had a job they loved much more because they got to devote their time and energy to caring for for patients rather than doing paperwork. So I think,
Also,
I think when we look at this question of who's in favor and who isn't, what I hear from doctors are, if I could find some way to get rid of the second story in my clinic, which is where all the claims and the billing clerks are stashed, I would do it in a all that money is going to be more available, that I'm paying them, which is a huge amount of money in any physician's practice, whether you're a psychiatrist like you were, Rick. My brother-in-law was a psychiatrist. I helped start the agency that provided mental health counseling there, and I'm very familiar with how much, what percentage of our income went simply to pay Sally and Raquel. They worked long hours and had lots of help. We added Maria, we added so-and-so, we added so-and-so.
Can I make one other point? I didn't mean to slam your brother, Adam. And to your question about fear, yes, it is a fear. But I think it's because doctors in general have a terrible lack of understanding of healthcare economics. That's one thing. The other thing is that in the past, when we've tried to control, when the country has tried to control costs of Medicare, one of the things they've done is every time you line up what you're paying doctors to what you're paying hospitals to what you're paying pharmacies, et cetera. And when push comes to shove, they'll chop the payments to the individual providers. So there is a rational basis for having a concern about that. But what they don't understand is when you cut out the 20% of overhead that the average provider pays for billing clerks and providing insurance to their employees and whatever else expenses they have from this, that you could actually take a cut in Medicare payments and still make more money. And the other thing is, what we want to pay providers is up to the system. I mean, if people want providers to be paid fairly and be able to pay off their student loans and whatnot, then the people need to say so. They talk about in Canada how long people have to wait for a knee replacement, which is greatly exaggerated, but there's some truth to it. But in order to fix that, all they have to do is put a little more money into the system. They're only paying half of what we pay for total costs, including out of pocket. If they wanted to pay a little bit more, they could take care of that problem.
Also, the bills that are being considered include money to help people get trained. And some of it would be more loan repayment and that sort of thing, so that we can build up the workforce to match what we know we're going to see. How about John Hawkins or John Hickok?
I just enjoy listening to you, Mike.
Yeah.
It seems to me that we are on the cusp with the particular presidential election coming up, as well as what's going on with our healthcare committee. I think we could be looking at some real success in the very near future, as long as we're out there doing our part, which is getting out to the people we know, that we have some sort of respect relationship with, and get them on board.
Thanks, John. How about Susan? You have a comment?
Well, I did talk to Adam about a few questions about people with disabilities, and he wants to ask the group if you guys are willing to help support people with disability with mental health.
Definitely. How about Rick? Can you answer that one?
Absolutely. I think there's a lot of consensus on that, even among the politicians, even among some of the more conservative politicians who talk a lot about the cost of things. most of us have had experience with either with personal experience with mental illness, or we know somebody who's had experience with mental illness. There's a number of people in Congress who've lost children to suicide. And so I don't think that will be a big issue when the money is not so much of an issue.
How about John Hickox? We just need to get acquainted with you, and Shelley Murphy. Shelley, are you okay? I got to ask to unmute.
Yeah.
There you go, I think. Are you there, Shelley?
Yes, I'm there.
Hi.
I was chatting with my sons over the weekend, and they see big problems with the professionals in the medical thing being willing or thinking they're going to get less pay.
Yeah.
I can't think.
Yeah.
Going back to 770, have they got their advisory board together yet?
Yes, they announced the members, and that is also on that website. From our area, Ron Green was chosen from Albany, actually. So how many members? I think maybe 30, something on that number. And another person from Corvallis. So yes, they have.
Who's the other person from Corvallis?
I will send you that name. It's a person I don't know.
Okay.
Shelley's
No.
been active. Go ahead, Shelley.
Oh, it's not someone that's been working with us.
No. So just to introduce Shelley, Shelley's been active with League of Women Voters and with Mid-Valley Healthcare Advocates. What else would you say that brought you into this, Shelley?
Betty Johnson.
Yeah. Betty Johnson, she recruited most of us here. Yeah.
She thought I'd be helpful because I knew how the government worked.
Yes. And how did you come to that knowledge, Shelley?
Through the League of Women Voters.
Okay, good. All right. The League of Women Voters nationally, Shelley, am I correct, have taken a position in favor of universal health care?
Yes, I worked on that study. It was in the late 80s. The position for universal health care was adopted, I think it was 1989 or 1990. And it's just been sitting there.
Time for us to stir things up, right?
Right.
I know we have just 3 minutes, right, Adam? We want to meet John if we can get him in. He may not be next to his computer. Go ahead, Adam. Yeah.
Well, speaking of stirring things up, yeah, Mike doesn't have a microphone, it looks like, or John doesn't have a microphone, it looks like.
Okay.
Speaking of stirring things up, a lot of members of my congregation are freaking out about this Supreme Court nominee and getting rid of Obamacare. What should I tell my congregation about this issue when it comes to healthcare?
Anyone want to start on that one? Well,
I don't think she has a record on that.
Well, I think I saw something that she has expressed her distaste for universal health care, and I'd have to find out what decision that was and how long ago. But if that happens and they take away, pre-existing conditions as a, protection of that, it may take us so low that it would be kind of like Europe in 1945. It would be an awful thing to go through, but it may actually hasten the day that we have a single payer system, unfortunately.
Also, there's a question of whether they can, the Supreme Court can outright make it illegal. Congress has the power, if they ever wanted to use it, to limit the Supreme Court's purview over specific issues. It's not very well delineated in the Article 3, and it is within Congress's power to do that. So they can claim that it's unconstitutional, but if Congress says, well, you don't have the power to determine that, that's the way it goes.
I think it's also important to remember that we are not trying to pass, fundamentally, HCAO is not working on a national level. It's our job right before our eyes to get universal health care here in the state and to support where we can Medicare for all, if that's the vehicle that's chosen nationally, and it looks like it is. And to that end, I think, Mike, you brought up something tonight that I haven't heard you bring up before, and I am fascinated. And we all know this, that the proposed Medicare for all, national universal health care, is very different from the Medicare we have right now. It's even different from the Medicare as it started out in, what was that, 65, although that was much better than what we have now. So making a clear distinction between that when we look at what we're going for nationally, which we are not doing right now, we have an election coming up in 6 weeks now. That's what we're going for right now, is Oregon, taking care of Oregon right now. But getting the people getting the information to people so that they realize that Medicare for all is not the Medicare we see right now.
Right.
At the national level. And I love that you brought that up. And I want to hear more about that. I want to hear that comparison list of what it looks like when it's done the way we want it to do, and the list that we have to be reminded about, because we're so used to the flaws of present day Medicare, we don't even think of them. And I'd love to see a list of those main flaws delineated.
Good, okay, we'll work on that.
Thank you for allowing me to be in on your.
Good.
Thanks
for joining. Yeah, thank you, Adam, for hosting.
Thank you very much, Mike.
Hey, Mike, thanks.
Okay.